This is a lecture on food-borne parasites. The main outcome for this lecture is to discuss specific food-borne parasites. Specifically, we aim to review general characteristics of food-borne parasites, to differentiate the morphologic features of these parasites, to illustrate the life cycles, to discuss the pathogenesis and the important or the more common clinical features, to discuss general diagnostic and therapeutic strategies, as well as to integrate all of these important concepts to answer a specific clinical case. Here is a list of parasites, specifically those that are acquired through ingestion of the infective stage. How would you then differentiate the so-called food-borne parasites? Some parasites are acquired through ingestion of food or water contaminated with the infective stage, usually contaminated by fecal matter. These parasites include your Ascaris, your Entamoeba, specifically Entamoeba histolytica, Giardia, and most coccidians. Technically, these are also considered food-borne parasites, but born through fecal contamination. However, some food-borne parasites can only become infective once inside specific organisms that eventually become foodstuffs. These include your tapeworms, which include your pork and your beef tapeworm, as well as your fish tapeworm, and some nematodes, such as Trichinella. Then there is this subgroup of foodborne parasitosis that are specifically caused by trematodes or flukes. These parasites are called foodborne trematodes or FBTs and include liver flukes like your Opisthorchis, Enclonorchis, and your Fasciola. These also include your lung flukes like your Paragonimus and your intestinal flukes. The rest of the lecture will focus on three genera of foodborne trematodes: your Fasciolopsis, Echinostomids, which include your Echinostoma and Artyfechinostomum, and three common species of Heterophyids. We will also discuss one relatively common foodborne nematode, the Anisakids. Taxonomically, the foodborne trematodes are highly diverse. There are at least 99 species, which include 15 species of liver flukes, 9 for lung flukes, and more than 70 for intestinal flukes. Estimated extrapolated foodborne trematodes, around 75 million infections as of at least the last polling, with hundreds of thousands of new cases annually and cumulatively about 2 million disability-adjusted life years. There are some generalizations that we can make for foodborne trematodes. The first one is that their first intermediate hosts are usually aquatic and marine snails, but usually aquatic or freshwater snails. Their second intermediate hosts differ depending on the parasite, but their infective stages are the metacercaria. The diagnostic stages for your foodborne trematodes are usually ova found in stools of infected humans. All of the FBT ova are operculated, but their sizes differ depending on the parasite. And usually, these sizes can tell you which parasite are actually the causative agent. To better appreciate the foodborne trematode discussion, let's take a look at this particular case study. We have a 13-year-old female from a rural province in China with an 8-year history of recurrent upper middle abdominal pain, which intensified in the past 5 days. There is evidence of anemia, malnutrition, and light tenderness of the upper middle abdomen upon palpation. Hemoglobin is around 112 grams per liter. neutrophils of 70%, eosinophil count of 7%, normal ALP and normal bilirubin, and ultrasound and MRCP or magnetic resonance cholangiopancreatography finding of common bile duct dilatation. Based on this case, what would be your primary working impression? Okay, so you don't have to stick with parasitology. Think about your differential diagnosis given this particular case, be it microbiologic or even surgical or medical. Now, let's try to discuss the first trematode on our list, the first parasite on our list, Fasciolopsis buski, or the giant intestinal fluke. The giant intestinal fluke is this one in the middle. Its length is about 20 to 80 millimeters or 2 to 8 centimeters. So this one, as far as parasites are concerned, is relatively quite big. Here are the relevant parts here. You have your genital pore. Actually, you have your oral sucker here up top. And then you have your ventral sucker here, or your acetabulum. The genital pore is somewhere here. Now, this one is your uterus. So these ones are your uterus. And this dark stained organelle here is your ovary. Now, these highly branched organelles are your testes. Organs are your testes. And on the side are your vitellaria. Okay, on the side are your vitellaria. And this dark path here, darkly staining organ here, would be your uterus. And now, on your left side is the fasciola adult. So please take note of the difference between your Fasciolopsis buski adult and your Fasciola adult. There are quite a number of similarities between the two. They're both macroscopic. They are both, the organs are the same. However, please take note of the relatively continuous anterior portion of your Fasciolopsis buski as opposed to the cephalic cone or the distinct triangular anterior end of the fasciola. So this is your fasciola, cephalic cone, while your Fasciolopsis buski does not have a cephalic cone. The anterior head, the anterior portion, is continuous with the rest of the body. Now on the right here is an ovum of your Fasciolopsis buski. This looks quite familiar. This looks actually very, very similar to the ovum of your fasciola. And as you can see, this is a relatively large ovum with an operculum. So it has a single operculum at one end. Very similar to your fasciola ovum. Now, compared to other parasite ova, your Fasciolopsis buski, quite similar to your fasciola ova, are relatively large. In fact, they are among the largest ova compared with other parasite ova. This is the life cycle of your Fasciolopsis buski. Take note that humans and pigs, usually pigs, are both your definitive host for your Fasciolopsis. So, ova are secreted, are excreted together with the feces of your definitive hosts. They are passed out as unembryonated eggs, and they embryonate in the presence of water. Now, again, also in the presence of water, once they embryonate, the miracidia would hatch and it would infect the first intermediate host, which are usually aquatic snails. However, in some cases, even marine snails or saltwater snails can also be the first intermediate host of Fasciolopsis. Now, inside your first intermediate host, it undergoes several developmental changes here until it becomes a cercaria. So the cercaria will extrude from your first intermediate host, and they will swim around in the water looking for its second intermediate host. So as you can see here, the second intermediate host is a greenish thingy, which we will discuss in a while. So these second intermediate hosts of Fasciolopsis are actually water plants. And these water plants would harbor the cercaria, which would eventually become the metacercaria, which is the infective stage of your Fasciolopsis. Now, your metacercaria embedded in your water plants will be ingested by humans or pigs, closing the life cycle stage. Now, the second intermediate host of Fasciolopsis, as I mentioned earlier, are water plants, which are ingested by either pigs or humans. Now, here are examples of these water plants. You have lotus, you have your Indian lotus here. You can also have Nymphaea lotus, which is the common lotus. You also have here your Trappa bicornis, or the water caltrop. You can see here, this is the water caltrop plant, and this is the water caltrop seeds, which looks like this one. Looks like a carabao head. You also have your Eleucharis tuberosa, or your water chestnuts. Now, you can actually see water chestnuts, canned water chestnuts in the groceries. For those of you who have access to markets, they have fresh water chestnuts in some markets. But I'm pretty sure a lot of you are familiar with this one. Your Ipomea obscura, or your water morning glory, or your kangkong. Now, the disease caused by Fasciolopsis is called Fasciolopsiasis. It usually manifests with abdominal pain, inflammation, and mild ulceration resulting to mucoid diarrhea, and obstruction signs and symptoms. Now, the obstruction signs and symptoms, as well as the other symptoms, are actually due to the presence of the adult worm residing in your small intestines, which being about 8 centimeters long and probably 2 to 3 centimeters wide. If you have a lot of them, they can clog up your intestines. Now, there are also intoxication symptoms associated with Fasciolopsis. Now, the intoxication symptoms are theorized to be due to the secretory products produced by the fasciola itself. The next parasite is your Echinostomids, which includes your Echinostoma and your Artyfechinostomum. These are called your spiny intestinal fluke, and we'll learn why they are called so. So this slide shows a picture of your adult Echinostoma. We're here. As with all flukes, it has an oral sucker here. So let me draw on the screen. You have your oral sucker here at the anterior end. You have your acetabulum here, or your ventral sucker. You have your other organs here, very similar to what you have with your Fasciolopsis. As you can see, the Echinostoma is more slender than your Fasciolopsis. And if you take a look at the size, it is around 5 to 12 millimeters in length. So it's a bit shorter compared with your Fasciolopsis. Zooming in at the anterior portion, so this is the anterior portion of the Echinostoma. If you zoom in there, you can appreciate all of these collar of spines. So the oral sucker is actually studded or surrounded with these collar of spines. And that's why it's called your spiny intestinal fluke. The left side shows the ova, which are a little over 100 micrometers in length. The ova are a bit smaller than the Fasciolopsis ova, and they are also operculated. So as you can see here, this is the opened operculum of this particular ova. This is also the operculum of this particular ova, which is closed. So you can appreciate the operculum of the ova. Usually for Echinostomids, the operculum is flattened compared with the abopercular or the opposite end. So this opposite end here is more pointed compared with the flatter opercular end. So here is the life cycle of your echinostoma. The definitive hosts are usually mammals or birds, and they pass unembryonated eggs into the soil, which eventually finds its way into water where it embryonates. And then the miracidia hatch from the embryonated eggs, which infects the first intermediate host, the snail. Now, again, very similar to your other trematodes, inside the first intermediate host, the snail, they undergo several developmental changes, eventually releasing your free-living or free-swimming cercariae. And the cercariae would then invade the second intermediate host. Now, compared to your fasciola and Fasciolopsis, the second intermediate hosts are not freshwater vegetation, but rather other aquatic organisms, which includes your other snails, your bivalves and crustaceans, even some fish, and even amphibians, such as frogs and tadpoles. Remember, a very distinguishing feature of Echinostoma is that its second intermediate hosts can be other snails. So not just their first intermediate host, but also their second intermediate host can also be snails. As I mentioned earlier, the second intermediate hosts of Echinostoma includes snails. And that being the case, when humans eat some aquatic snails, they can be infected with echinostomids. But of course, not all aquatic snails can be the second intermediate host of Echinostoma. So we have here two important and specific aquatic snails. You have your golden apple snail. Actually, this is just oh yes. So this is your golden apple snail, which is a common second intermediate host of Echinostoma. In the Philippines, you also have your Pila luzonica or your golden kuhol, which is usually the second intermediate host of Echinostoma ilocanum. So for those who are living in the northern region of Luzon, in the Ilocos region, I'm sure you're familiar with the delicacy there, your golden kuhol. On the bottom part of your screen, on the bottom part of the slide, this is your viviparid snails from Thailand. This is a picture taken from a study of Thailand wet markets. From this particular study, what they found was that the prevalence of infected snails in these wet markets can go up to around 17%. So a big percentage of the snails from their study, which were sold in wet markets, were actually infected with echinostoma. The disease associated with echinostomids are usually asymptomatic in most people. However, if they are symptomatic, they usually manifest with epigastric pain. And this is quite telling. This is quite different compared with the other manifestations of other food-borne trematodes. So the epigastric pain is usually due to intestinal erosion or ulceration, which can eventually develop into not watery diarrhea, but bloody diarrhea. And this epigastric pain and in this intestinal erosion is primarily due to the oral sucker, which is armed with the spines, which we described earlier. So the spiny intestinal fluke actually causes intestinal erosion and intestinal ulceration as it attaches its oral sucker into the intestinal mucosa, which causes bloody diarrhea and epigastric pain. Now, the intoxication symptoms are also present, very similar to your Fasciolopsis. Again, this is primarily due to the excretory and the secretory products directly produced by the echinostomids. Gratzik and Fried in 1998 They describe the common features or the common symptoms associated with echinostomids, from light to moderate infections causing anemia, headaches, dizziness, non-specific findings. But for heavier infections, they are associated with eosinophilia, more significant abdominal pain, profuse watery diarrhea, some cases bloody diarrhea, significant anemia because of the blood loss, edema, and more prominent anorexia. The next parasite to be discussed would be your heterophyids, which are your very small intestinal flukes. Now, I just coined the term very small intestinal flukes. They're just intestinal flukes, but as we'll take note later, they are very small in size compared with the other intestinal flukes that we've discussed earlier. Now, we have three species of heterophyids which we will be discussing: your Metagonimus, Haplorchis, and your Heterophyes. All of these three are called your heterophyids. The first one is your Metagonimus, and if you take note of the bars here, these vertical bars are about 100 micrometers in length. So this is 100 micrometers. So in total, the length of your Metagonimus is about 800 micrometers, or less than 1 millimeter, about the size of a tip of a pen. So it's very microscopic. Now compare this to the size of Echinostoma, which is about the size, about the length of a fingernail, around 1 centimeter in length. Now compare this again with the length of Fasciola or Fasciolopsis, which can be as long as a thumb. So as you can see, your Metagonimus is, or your heterophyids in general, are quite small compared with your Echinostoma, and definitely compared with your Fasciolopsis. Now let's try to identify the parts of your heterophyids, particularly your Metagonimus. So you have your oral sucker here, at the oral part, at the anterior part. You have your acetabulum or your ventral sucker here in the middle. It's not quite clear here. It's somewhere here, and it's so here. Now, A, B, and C are different species of Metagonimus, but as far as we are concerned, we'll not try to differentiate between these three species of Metagonimus. You also have your posterior testes here. Usually, Metagonimus have two testes, this one and this one. You have your ovary here. Okay, ovary here. And all of these brown things here distributed are the vitelline follicles containing the ova. Actually, all of these brown things are the ova of your Metagonimus. Take note of the gonotyl. Gonotyl, when we are discussing heterophyids, we will be discussing the presence of gonotyls. Now, gonotyls are muscular suckers surrounding the genital pore. Now, genital pores are openings near the acetabulum or the ventral sucker. So the genital pore is somewhere here. It's quite small. We can't really see it from these pictures. So it is connected or intimately located near the acetabulum or the ventral sucker. For your Metagonimus, it does not have a gonotyl. It has a genital pore, but it does not have a muscular sucker surrounding the genital pore. So it has no gonotyl. In contrast, the second species of heterophyids, your Haplorchis, has gonotyls. Okay, so if you take a look at the lower pictures here, these are the gonotyls of your Haplorchis. Now, where are these gonotyls located? They are situated near the ventral sucker of Haplorchis. So we have to locate first the ventral sucker. So this is actually the ventral sucker of this Haplorchis. The ventral sucker here is somewhere here. It's not very clear. Oh, definitely not clear on this picture. But the gonotyl are located just beside your genital pore. So if you, rather your acetabulum or your ventral sucker. So if this is your ventral sucker here, let me try to illustrate. So if this is your ventral sucker, this is where you will see the gonotile. So let's try to remove it and try to see it again. So this is your ventral sucker, and the gonotile is somewhere here. It's not quite clear here on pictures C and E. So as you can see, the gonotile of your Haplorchis have these spines or sclerites. Quite similar to the Echinostomium spines. But in this case, it's not found in the oral sucker, but rather in the gonotile. Another distinguishing feature of Haplorchis, which is actually just nice to know, is that compared with the other Heterophyids, it only has one testis. So this is the single testis of Haplorchis. Actually, here it's not really very clear. Probably this one. While the other Heterophyids actually have two testes. Now, the third Heterophyid is your Heterophyes. Heterophyes. So that is this complete scientific name. It also has a gonotile, but instead of your spicules, it has your rodlets. Doesn't really, you can't really appreciate it very clearly, but these tiny rodlets here, very similar to the spicules of your Haplorchis. All of these are rodlets surrounding the genital pore. So the genital pore is somewhere here. This is the genital pore. So this is the genital pore. It is surrounded by a muscular sucker called your gonotile, which is intimately located near the very muscular and very prominent acetabulum or ventral sucker. So these are the ventral suckers, very prominent in Heterophyes. And this is the genital pore, or the gonotile rather. This is the gonotile of your Heterophyes. There. So zooming in, this is what it looks like. Okay. Now this is the life cycle of your Heterophyids. The Heterophyids have a very circular life cycle, very simple life cycle. Okay, so humans are the definitive hosts, where adults live in the small intestines, very similar to your other intestinal flukes. Humans pass out embryonated eggs in the feces, in stool, and once the embryonated eggs are released into the environment, the miracidium will hatch from the ova, and it would try to look for the first intermediate host, a freshwater snail. And again, very similar to your other flukes, the cercariae will develop from the miracidium inside the first intermediate host, and it would go out of the first intermediate host, and it will look for its second intermediate host. Now, in this case, the second intermediate host of Heterophyids are freshwater fishes, where the cercaria will lodge into the tissues of the fish, usually in the muscular region or the gills of the fish, and it would develop into its infective stage, the metacercaria. Now, if these freshwater fishes are ingested by humans, then that would complete the life cycle. Now, the second intermediate host of your Heterophyids, which we mentioned earlier, are freshwater fishes, include perch. These also include mullets, gobies, and even tilapia. I'm pretty sure most of you are more familiar with tilapia. So these are freshwater fishes, and the principal mode of infection is consumption of raw or improperly cooked freshwater fish. In some cultures, pickled, salted, or fermented fish, as well as contaminated cooking knives or chopping boards, can also transmit infections because of contamination with the infective stage, your metacercaria. Endemic areas are usually in Far Eastern countries, including Korea, Japan, China, and Russia, and also including Thailand. If you recall, in Thailand, fish delicacies such as koipla and plara were documented to also harbor these small intestinal flukes, and not just the liver flukes. The disease caused by heterophyids usually manifests with abdominal pain and watery diarrhea. Mechanical irritation is chiefly caused by the movement of worms, which can cause harmful effects to the mucosa, particularly in the villus and the crypt layers, hence causing poor absorption of secretions, causing watery diarrhea. Now, chemical substances produced by flukes, which are your excretory and secretory products, also plays a role in the manifestation of your heterophyid disease. Very similar to the excretory secretory proteins secreted by the liver flukes and the other intestinal flukes. The main habitat of heterophyids are the villi and the crypts of the small intestines. And as we mentioned earlier, these worms can cause mechanical and chemical stimuli to the host intestinal mucosa. In most cases, in immunocompetent patients, these worms never invade the deeper layers of the submucosa and the mucosa or even the serosa. However, in immunocompromised individuals, they may invade deeper beyond the mucosa. If they reach the deeper levels, pathological changes in the mucosa leads to difficulty in nutrient absorption of the intestines, which primarily causes the secretory diarrhea. There is also increase in the permeability of the intestinal mucosa reported in experimental mice. This was a study way back in 1984 by Onishi and Taufen. The resulting watery diarrhea seems to be due to the poor intestinal absorption of secretions and the destruction of the intestinal mucosa. Clinical manifestations due to metagonymous primarily and other heterophyid infections are generally mild and transient, unless the patients are heavily infected, complicated with other diseases, or, as we mentioned earlier, immunocompromised. Again, the most frequent clinical symptoms in heterophyid infections include abdominal pain, diarrhea, lethargy, anorexia, malabsorption, and subsequent weight loss. Now, the severity of clinical symptoms is closely related to individual worm burden. Now, these are primarily found out by Chai in 2015, wherein in immunocompromised individuals, where worm burden is increasingly high, heterophyid infections may cause severe clinical manifestations and possibly includes erratic parasitism, erratic migration to organs such as the heart, brain, and spinal cord. Our last parasite for this lecture is your Anisakids, or your herring worm. These includes Anisakis and Pseudoterranova.
We're in Costco right now. Okay. And look at
the worm.
look at that guy. He's happy as hell, just cruising around in there.
Wow.
Yep.
Because they have these things in them, huh?
Maybe they'll give me a discount on that one.
Huh.
That's what I'm talking about, though. They're loaded with those parasites. I don't know what they are.
Those are dukes, no?
Right here. Fresh coho salmon. It must
fresh.
be. It must be fresh. Hell yeah.
Anisakids are intestinal nematodes. They are not intestinal trematodes, so they are roundworms and not flukes or flatworms. Take note that we are more concerned only about the third stage larva, and these third stage larvae are about 1 to 2 centimeters long. This is the life cycle of Anisakids, which is quite different from the life cycle of the other parasites that we've been talking about. Definitive hosts are marine mammals. So marine mammals. So Anisakids, Anisakiasis, which is the disease caused by Anisakids, So Anisakiasis is a disease from the sea and not from fresh water. So this is one differentiating feature of Anisakid. So definitive hosts are marine mammals like dolphins, seals, whales, sea lions, etc. So the definitive host will poop out the unembryonated eggs in salt water in the sea and the ocean, and they would embryonate in salt water, producing third stage larvae. The third stage larva will hatch from the eggs as ensheathed free living forms, or free swimming forms rather. And again, these are nematodes, so they do not produce miracidium, they do not produce cercaria, but rather third stage larva. But similar to your cercaria, which swims around in fresh water, your third stage larva swims around in salt water looking for their parathenic hosts, which are primarily the crustaceans, the shrimps, crabs. These are smaller organisms, and they would reside inside the digestive tract of your shrimps and your octopus and your crabs. Now, these smaller organisms, the parathenic hosts, get ingested by bigger hosts, and in this case, bigger parathenic hosts, such as your marine fishes. So again, you have your marine crustaceans being ingested by your marine fishes, and eventually these marine fishes, which ingested contaminated prawns or shrimps or crabs, they get ingested by the definitive host, which completes the life cycle. Now, of course, humans also ingest marine fishes. Humans also ingest marine crabs, octopus, shrimps. Humans can also get infected. However, in humans, Anisakids do not develop into adult hosts. As you can see, the life cycle stops if humans ingest it. They do not continue because Anisakids do not develop into adults inside humans. So that's why we are only concerned with the third stage larva for humans as its infective stage as well as its diagnostic stage. As you can see, the third stage larva here did not develop from here to here to here. These are all third stage larva, third stage larva, third stage larva, and up until the ingestion of humans, still third stage larva. It only progresses from third stage larva into adults inside the definitive hosts, your marine mammals. Humans are not marine mammals. So knowing this life cycle, what do you think are the foodstuffs more commonly causing your Anisakiasis in humans? So think about it. Now this is a platter of foods which can be the source of Anisakids. This is very yummy. Examples of foods that are at risk for Anisakis infections are sushi, sashimi, smoked herring, includes mackerel, salmon, halibut, sardines, ceviche. You have anchovies, salmons. You have your smoked salmons, your salted in brine. Oh, I'm getting hungry just discussing all of these. This also includes octopus or squids. You have your shrimps, as I mentioned earlier. You have prawns, lobsters. All of these very yummy foodstuffs can harbor Anisakids. Now, as I've mentioned earlier from our discussion in the life cycle discussion, the larva, particularly the third stage larva, causes disease. Adults do not develop inside humans since once larva gets inside the human, they will die there and they will not develop further. The manifestation of Anisakiasis is primarily sudden and severe upper abdominal pain. Again, Anisakiasis usually manifests as sudden and severe upper abdominal pain. What does this remind you of? Yes, Anisakiasis is a differential diagnosis for peptic ulcer disease. You have your sudden and severe upper abdominal or epigastric pain. Now, there is evidence of granuloma formation in recurrent Anisakiasis or Anisakis infections, but the European Food and Safety Authority, EFSA, in 2010, acknowledged that Anisakis or Anisakis simplex allergens are highly resistant to heat and freezing. And therefore, treatments which kill Anisakids in fishery products may not actually protect the consumer against allergic hazards due to the infection or due to the ingestion rather. Even if you kill the Anisakids by freezing your fishes or your squids, the allergens are actually resistant to freezing and even allergic to resistant to heating. Therefore, Anisakis infections or Anisakis contaminations rather can actually cause allergic reactions as well. So, allergic reactions are a function of chronic exposure. So, for those of you who like to eat Anisakis contaminated food chronically, then you are more at risk for Anisakis-related allergic reactions. Anisakiasis being very clinically similar to peptic ulcer disease, you have to differentiate between peptic ulcer disease versus Anisakiasis. Now, there are two types of Anisakiasis. You have your gastric versus your intestinal Anisakiasis. So the gastric Anisakiasis mimics peptic ulcer disease, while the intestinal Anisakiasis mimics appendicitis or diverticulitis because it is lower in the gastrointestinal tract. Another problem with Anisakiasis is that Anisakiasis is often misdiagnosed as an acute abdomen or intestinal obstruction and is treated surgically. According to a report by Ishikura, 1983, intestinal Anisakiasis was correctly diagnosed in only 23% of cases, whereas in 38% of cases, they treated it as acute appendicitis, and in 12% of cases as intestinal obstruction. So that is problematic because all of the latter disease entities are treated surgically. But what we will learn later, Anisakiasis is only treated medically. The diagnosis of food-borne parasites, particularly the 4 parasites that we've discussed, is mainly through stool exam. So looking at the life cycle earlier, the stools of humans contain the ovum or the ova of your Fasciola, Echinostoma, and your Heterophyids. However, for Anisakids, remember that humans do not produce adult Anisakids, so they will not produce the ova of Anisakids. So therefore, in order to diagnose your Anisakiasis, you have to do endoscopy of the stomach or the early part of the small intestines, or you can do biopsy or in rarer cases autopsy to actually visualize the third stage larva living in the stomach or the intestines. Another option for Anisakiasis would be a serology. So the only option for intestinal Anisakiasis would be to look for anti-Anisakis IgA or IgG or IgE. The treatment for food-borne parasites would be very simple. For your Fasciolopsis, Echinostoma, and your Heterophyids, which are all trematodes, you give the magic drug for trematodes, which is praziquantel. For Anisakids, you only do conservative treatment. You give painkillers plus symptomatic treatment for whatever other symptoms the patient is manifesting with, since the larvae live in the human gastrointestinal tract for only 2 to 3 weeks. You only need to manage those 2 to 3 weeks, the pain that the patient manifests with, because again, the third stage larva eventually gets killed by the human body. In some cases, they found out that albendazole can help speed up the process. In some cases wherein the patient is really manifesting with severe pain and the patient was diagnosed through endoscopy, you can actually remove the third stage larva from, let's say, the stomach lining through surgical intervention, usually by picking it up directly with your endoscope. To wrap up the discussion, let's go back to our case study. 15-year-old female from China, 10-year history of recurrent abdominal pain, which intensified in the past few days. And additional findings, we have the patient was suspected of biliary stones with cholangitis based on the ultrasound and the MRCP, which was performed. But there was no response to the biliary stone medications. So they eventually did exploratory laparotomy of the common bile duct, and they found a flat foreign body from the middle of the duct, 1.6 by 1 by 0.1 centimeter in dimensions, which looks like this one, with a sucker at the front and a tail-like object. So these are actual case study descriptions. Careful observation showed that this particular object, could move. So this is the actual biopsy specimen, the exploratory laparotomy specimen that they got from this particular case. So, given all these, a case by Wu et al. 2020, what is your diagnosis? What is your treatment of choice? So to answer, the diagnosis is Fasciolopsiasis. The causative agent is Fasciolopsis buski, or the giant intestinal trematode, or the giant intestinal fluke. What's the treatment? It is praziquantel. As a final note, I'd like to show this to you, the parasite ova size comparison, so that you will have an idea how big the ova are of the different intestinal trematodes that we've discussed in this lecture. To give you an idea, your Fasciola hepatica and your Fasciolopsis buski are quite similar, and they are among the biggest ova among all the parasites with ova. Your Echinostoma is not far behind here. This is your Echinostoma ova, which actually looks very similar to your Fasciolopsis buski and your Fasciola hepatica ova. And as you can see here, these are the bigger ova of your food-borne trematodes. And let's look at your Metagonymous Heterophyes, and you don't have your Haplorchis, but their ova here are quite similar. They are among the smallest ova, measuring just around 30 micrometers compared with around 150 micrometers for Fasciolopsis and your Echinostoma. So again, Fasciolopsis buski, quite big, Echinostoma, quite big as well, and your Heterophyid ova, quite small. So this can give you an idea when you look under the microscope whether it is a Fasciolopsis buski ova, Echinostoma ova. Probably you can't tell the difference, but at least you can differentiate these two from the Heterophyids. And together with your clinical history, together with the symptomatology, you can decide which is the offending agent more accurately. As a final note, I'll leave this to you to think about. Knowing the life cycle, the pathophysiology, the foodstuffs that are associated with the different foodborne parasites, including the foodborne trematodes and your Anisakis, looking at the different first intermediate hosts, knowing that there are different second intermediate hosts. How do we then address foodborne parasitosis on a public health level? So think about this and please put in the comments your answers or discuss amongst yourselves.